I would like to welcome everyone for attending today's Improving Ohio's Health webinar. This is part of our Improving Ohio Health series. The title of today's webinar is Effective Use of the HIE Tools for Managing the Care of Patients with Prediabetes, Diabetes, and Hypertension. My name is Scott Mash. Let's take a real quick look at our agenda. We're going to talk about, just from a very high level, a few of the chronic conditions that we are going to focus on within this webinar, which are, of course, prediabetes, diabetes, and hypertension. From a very, very high level and very quickly, we're going to talk about a health information exchange and how it can help you manage the patients. We're going to focus on use cases, and then just very quickly at the end, touch on the future of HIE and analytics. I have a lot of slides to go through, so some of these we'll go through very quickly. Now, this session is being recorded, and the slides will be made available to everyone who's attending. You can download them right now, as a matter of fact, through the GoToWebinar app. Let's not forget, November is American Diabetes Month, with November 14th being World Diabetes Day. You know, don't miss this opportunity to educate your patients, to really focus on diabetes within your practice. Just anything you can do to prevent one patient progressing from prediabetes to diabetes is a huge win. And again, we are using GoToWebinar. You can download your handouts. If you want to ask a question at any point during the webinar, you can click on the questions button, type in your question. At the end, I'll take the time to read and answer every one of the questions. So real quick, let's talk about what is prediabetes. Well, prediabetes is someone who has an elevated blood sugar level but has not yet got to that point where you would consider them to be full-blown diabetes. Diagnosing someone with diabetes or prediabetes is an opportunity to prevent diabetes, because just with simple lifestyle changes, no medication, you can prevent that progression of the disease. So why is it important to focus on prediabetes? Well, 84 million Americans 18 or older have prediabetes, and that's a third of our population walking around with prediabetes. 23 million of those are ages 65 or older. And it is spread across all of our ethnic groups. So you can, by simple management and lifestyle changes of prediabetes, you will stop the progression. The diabetes prevention programs, if you've read any studies on those programs, the success rate is outstanding. Really make use of those programs for your patients. Hypertension. Well, we've got 11 million Americans that are walking around that have high blood pressure but are not receiving treatment and maybe have never been diagnosed with hypertension. We got 75 million Americans that are at risk for, or higher risk for, heart disease and stroke, and about 1.5 million every year that do suffer a heart attack and stroke. Here in Ohio, more than half of Ohioans I'm sorry, I read that wrong. In 2015, more than half of the hospitalizations here in Ohio, those patients had a diagnosis of hypertension. So what is undiagnosed hypertension? Well, they kind of break it into two stages. If you are below or up to 140/90, they say you have an undiagnosed stage 1 hypertension, and then if you're up to 160/100 or higher, you're stage 2 undiagnosed hypertension. And really, you know, if you do have a patient come into your office, they have 2 past readings of high blood pressure, consider the diagnosis of hypertension or treatment, a temporary treatment of hypertension even, to help lower them back to a manageable level. So now we've talked about the conditions we're focusing on today. Now let's transition over to an HIE. Why do you want to use an HIE? What is the impact? What is the effectiveness? Well, there's been several studies done on HIE, and if one HIE was implemented across the nation, EHRs were truly as interoperable as they should be. we could save, as a nation, $77 billion each year. Also, the use of an HIE across the continuum of care would allow folks across the continuum, policy makers, stakeholders, public health, and of course all of the traditional healthcare providers to make more informed decisions, to really focus on population health, for the government to set aside enough funds to truly care for those patients that are in need of assistance. There's a million studies out there on HIEs, and they all do say that an HIE does improve the care and efficiency and patient safety because you have all of the patient information, or at least more of the patient story than you may have contained in your EHR. HIE does facilitate communication amongst providers. Data can easily be sent from a primary care to a specialist and back from that specialist to primary care. We can close that referral loop. Of course, an HIE does supplement your quality care measurement. If you have struggled in the past with the diabetes A1C poor control, get integrated with the HIE so you can receive results electronically. That way, when one of your patients does go get their A1C, it just flows back into your EHR upon completion of the test, and you will get credit for that patient being in compliance with the A1C orders. And of course, when you have all the information, it does decrease healthcare costs because you're not reordering tests that perhaps they received at a local ED during an inpatient stay or from any other provider of care. Of course, again, these same studies will say that an HIE does lead to healthier patients because you have fewer medical errors due to having the entire patient story, or again, more of the patient story than you had before. It is more efficient. You're not having to go to your fax machine, get the lab order that was completed on your patients, scan those into your EHR, or maybe even key in a few of them. Everything just flows right in. And again, we're lowering the potential for repeat tests and procedures. And again, you do have the opportunity to make more informed treatment decisions, especially as we expand the contributors to the HIE across the care continuum to maybe even include some of these social services that might be able to contribute some of the social determinants of health that aren't collected in other more traditional care settings. So let's take a look at the CliniSync HIE real quick. The CliniSync HIE, we have, of course, our very first focus was on the hospitals. We have 155 hospitals now that are part of the HIE. Of course, we have the physician groups, behavioral health, long-term care, the post-acute care settings. Health plans are coming on board. We have public health. We're bringing on commercial labs. We're really working diligently to bring on both contributors of data and receivers of data across the care continuum. Here on the right-hand side of the screen, you'll see a nice infographic to provide you some details of CliniSync, but I want to focus on that first one. 12.2 million unique patients have been indexed within our master patient index. If you kind of go down that point, you'll see that we have 5,500 users of the community health record. There are 500 long-term and post-acute care facilities receiving information from the HIE. We're working hard to get those same organizations contributing data as well. We are integrated with 42 different EHRs, but the most important part of this is that's one HIE that has all of this information across Ohio. So let's look at a real specific use case for a patient with diabetes and hypertension and how the HIE can supplement the care of that patient. We're going to start here in the upper left-hand corner where it says we have a new patient. They present to a provider. That patient says, hey, I've got hypertension. So the physician can log on to the community health record, query the HIE, say, okay, I have Bob Smith here in front of me. I want to see Bob Smith's information. So he reviews the A1C, the glucose, the BP problems, past notes, and whatnot. And while doing so, the provider notices that in one of the historical A1Cs from the last year or so that he kind of sees an A1C higher than he's comfortable with. Maybe it's not up to diabetes, but the patient hasn't been diagnosed or told they have diabetes. They just said, hey, watch the A1C in the past. Well, he's seeing some problems with that patient, doesn't like what he sees, so suspects diabetes, sends that patient to an endocrinologist. That specialist can receive that information via the HIE, have the same view of information that the previous provider had, evaluate the patient. Maybe they say, yep, this patient really does. The endocrinologist determines that the patient really does have hypertension, so he develops a care plan, detailed care plan for that patient. That care plan can be sent via the HIE, so the primary care provider, the new primary care provider for that patient, has access to that care plan, and then can develop, can enhance that care plan for that patient. And the great thing is the patient doesn't have to carry papers from one provider to the next. They really don't have to remember what medications they are, though we would really like that, but they always forget a med or two. All that information can be stored in the HIE, and a huge portion of it is growing every day. So we're going to talk about each of the HIE solutions or tools that are listed here on this slide. Clinical results delivery, that's kind of the bread and butter of the HIE, and that's the receipt of electronic discrete results directly into your EHR. Also, we're going to talk about the community health record. What this is a longitudinal health record of all the information that's been passed through the HIE or contributed to the HIE. Of course, the notify is an alert for an admit or discharge into the ED or into the inpatient setting. Contribute, just what it sounds like, the contribution of data to the HIE. And of course, there is a referral tool, a web-based referral tool. We're going to talk a lot about that towards the end of this webinar. Also, I don't want you to forget that your HIE enhances the functionality within your EHR, notably your clinical decision support. If you have a CDS rule set up to flag every patient that is overdue for an A1C, all your diabetes patients that are overdue for an A1C, or let's say you have hypertension patients, you have a CDS rule set up for them that if they're overdue for a lipid panel, that you get flagged within your EHR. Well, if you're receiving those results electronically through the HIE, all those results for all those patients, your CDS rules are going to accurately fire and be an accurate representation of your patient base, because there's nothing worse than getting an alert on a patient while you're sitting there saying, oh, this patient's overdue for an A1C, and then you click down through their medical record and you find out that, yeah, they had an A1C, but it was faxed in. And so your EHR cannot pick up that image to understand that, yeah, the A1C is there and the A1C was within the desired range. And also, you can increase your reimbursement through the use of an HIE. A lot of folks question this, saying, it's really hard to prove an ROI. Well, transitional care management, that's a no-brainer. You receive a notification, you get that enhanced reimbursement for seeing that patient within, calling them within 2 days of an ED or discharge event, and then seeing them in the office between 7 and 14 days. Also, if you are receiving clinical results through your EHR, that is going to improve your quality score, so that if you get above that, that magical MIPS composite score number of 70, then you have the opportunity to receive a little bit of a bump in your reimbursement. And also, some of your private payers have quality programs as well. And if you're contributing data to the HIE, some of those payers are contracted with the HIE to receive information, so that could be a benefit as well. All right, now we're going to talk about clinical results delivery. Like I said before, what it does is it allows that integration point with the HIE, allows all the results that for your patients to flow into your EHR electronically. That's lab results, radiology, we can do transcribed reports, and we can deliver those results if you have an EHR or if you don't even have an EHR. We work with a lot of the post-acute facilities that do not have a full EHR, so we can deliver those in PDF. We can deliver them in many different formats. But the benefit, again, is direct EHR integration. Those results flow pretty much the minute that they're completed within the lab. Most of the hospitals, if not all of them, that are contributing data to the HIE, as soon as that result comes through the machine, that result flows out to the HIE and over into your EHR. It happens in real time. And it is a huge improvement in efficiency over faxing or having to log into another facility's portal, or God forbid you get these results via snail mail. And again, as I said before, the integration of results dramatically improves the functionality of your CDS rules. We talked about this example before. And again, it does improve the accuracy and quality of your improvement initiatives. If you're doing care management within your organization, it supplements the information that those that are providing your care management functions, has to react for a patient, or just all the way around supplements information. Now let's shift over to the community health record. This is a statewide longitudinal patient record. You have information that the hospitals have been contributing data to the CHR for quite a while. It includes their discharge instructions, their encounter information, their ADT, which includes the insurance information and face sheets. We've seen some real interesting use cases from the CHR. Of course, the oldest use case that we started with was in the ED setting. You have a patient who has had an accident, they're unconscious, they're wheeled into the ED. I have a ton of respect for an ED doc, because I don't know, how do you care for that patient? You know nothing about them. You have their ID, so you know their name. Well, how in the world do you care for that patient? Well, if you log into the CHR, put in the patient's social security number, you can get at least, maybe the patient has some very basic information. You know what meds they're on, you know what their problems are. Well, at least now you can maybe not do any harm by treating that patient. Now we're seeing a ton of other use cases. The first time a patient presents to a primary care provider, or a patient was seen in the ED the night before and goes to their doctor the next day. Well, that doctor may not have those discharge instructions. Maybe the patient lost them. They can go into the CHR and get them. Of course, there's always that demographic and insurance information that is gold in some cases. And through the CHR, you can download you can create a CCD and download that into your EHR. And also, when you query the CHR, you are meeting the ORS requirement, because on the medications tab, which we're going to see some screenshots here shortly, we do present all of the ORS information. How does all this work with the CHR? Well, we have a ton of data contributors out there, and we always need more. Our goal is to capture the entire patient story. But the data that's contributed, it's registration data, it's transcribed data, there's the discrete visit data, the problems, the meds, the allergies, there's radiology reports, there's all of the labs, the micros, the paths, all of this data that flows over to the HIE. This is where the real work really begins, because we have to build that master patient index. These bullets here in the middle are probably in reverse order of what they should be. We receive that ADT information so we can build a master patient index, and do all the patient matching for all of these little tidbits of information that flow in. Well, then we try to consolidate that data. We try to normalize it as much as possible. We'll dedupe that data so that when you query the CHR, you get a nice record that presents of all of this information that is usable, that is readable and actionable. We're going to take a quick look at some screenshots from the CHR. These are real screenshots. Of course, they're test patients, but here what I want you to see is down the left-hand side of the screen. You have what we call our patient ribbon. You can see there's patient summary, encounter, results, meds, documents, referrals. That stays visible as you traverse through the system. You can see here on the summary screen, you get a really good quick snapshot, which you can click on any of these items and get more information. The demographics in and of themselves are gold for many organizations. I know I hear this a lot from the post-acute organizations that we work with that are now receiving data. Many times they'll get a patient, they'll get a few pages of information, and you know maybe the patient has their old medical card, or they didn't receive any insurance information. You can get that within the CHR. And you get face sheets. And again, this is all built from contributed ADT data primarily from the hospitals, but we are receiving data now from ambulatory care settings as well. You get that encounter level data. The results, regardless of where the results come from or how they flow into the HIE, we present them in the same style of view. So you don't have to decipher how different results may look. We try to do everything in a standard format as much as possible. You can see down here at the bottom, or in the middle, you can filter results. You can look at just a final, just a preliminary. We give you a couple options of the different types of results. You can filter by date range. So much filtering you can do, or you can just hit search and it's going to show you everything, and then you can click through. This example here, we don't have any medications or allergies listed, but now on patients you will see all this information. You'll have a good medication history down at the bottom. You can also see that our Documents tab will have those discharge instructions, encounter level instructions. The Referrals tab will have the referrals that were generated using the CliniSync referral tool, which we're going to look at later. And again, here on the Medications tab, when you go to the Medications tab, you've queried a patient, you've met the ORS requirement. Again, let's talk about a few more use cases for the community health record. You got access to information on new patients that present to your practice. Whether you're in primary care, you're a specialty provider, urgent care, ED, you're going to see a lot of new patients. So again, you can, one use case, you're viewing the CHR, you notice high BP across maybe a couple care settings, but no diagnosis of hypertension. You take a closer look at that patient. Over time, you can then move on. You could say that patient had undiagnosed hypertension and begin treatment on that. Because many times what we'll see is where an undiagnosed hypertensive patient is undiagnosed because maybe they don't have a BP reading in the past year in the same setting of care. But if you look at their ED, you look at when they went to the specialist, you can see a high BP across several settings of care in a short period of time. Yeah, many times the patient's nervous, but you might be able to move forward with that diagnosis. Physician accessing the hospital records for a recently discharged patient that had diabetes. They can look at their discharge instructions, see what medications they were given during that stay, review what their glucose levels were, and then adjust the medications accordingly there at that primary care visit. One of the services we've rolled out here in the last year, which we've had tons of great feedback for and tons of interest in, is the Notify, which is the admission and discharge alerts. The way this works is you're going to get, anytime a patient presents somewhere within Ohio, within one of our contributing hospitals, you will get a notification in near real time. Now, this notification does include some minimal information, hopefully enough to react if you're choosing to do maybe ED interventions or whatnot. But really, the design of Notify, or kind of the first use case that we think of, is case or utilization managers. They can be alerted to the ADTs for your high-risk population and manage that population accordingly. The way Notify works from a setup perspective or from an IT perspective, you tell us your patients, you give us enough information so that we can build the link within our master patient index. Then you tell us how you want those events, and we make it happen. You know, another great benefit of Notify is that through these very timely notifications, you can make a dramatic impact on your 30-day readmissions. Because if you've got a patient that, you know, is coming out of the ED, coming out of the inpatient setting, you're going to know. Many times, you know, I hear a lot from providers out in the field that a lot of times they'll have a patient come in and say, hey, I was in the ED last week, and, you know, they didn't know how to, why that patient was in there. If they could have been prevented from going into the ED, with Notify, you get that information. Now, we can send you notifications by text and by email. We don't really roll this out a lot. I don't think we have anybody that's live on this because, for one, you're going to get these emails every time a patient's seen, or a text in the middle of the night, 100 texts in the middle of the night on, you know, if there's a full moon out. But the information that we can send you via these manners is extremely limited, kind of because of PHI. We can more or less say, hey, you got an event, go log in and check it. Not a lot of value in that. What we see most folks using, and that I personally believe has the highest value, especially for large healthcare systems that have case managers, is the web-based work list view. You can see here, this is a web-based portal that we provide. Someone logs in and they get all of the events present that for the patient list associated with this account. Now, in addition to the ED and inpatient admits and discharge, you can see here we also are able to send, if you look at the third notification down, it's a notification of patient death. So that, again, you can update your EHR appropriately. You can reach out to those patients, you know, within the transition of care management requirements, where you got to make contact with the patient within 2 days, get them in the office between 7 and 14 days. Now you can do it, because now you can see where your patients were and you know when they've been released, so that you can then reach out and make contact with them. Let's look at a couple use cases with Notify. So you've got, I'm sure everybody has at least one patient that does a really poor job at managing their glucose levels. Well, say that patient is having a really bad day, they present at the ED, they're admitted for weakness, confusion, it's just due to a skyrocketing glucose level. Well, the primary care provider can get that alert, reach out to that hospital and say, yeah, Bob does a real bad job, take care of him, here's what we've tried in the past, just kind of reinforce what we're doing, and then when Bob's released, the primary care provider is going to get another alert saying, Bob's on the street, get him into the office. That way he can schedule that appointment, get him in, perhaps prevent that patient from going back in the ED. Again, when you're preventing that readmission, you're definitely helping the hospitals on their readmission rate, but don't forget, providers are evaluated on the total cost of care for those patients that are attributed to them. If you're in an ACO, the readmission is a critical measurement for the ACO receiving shared savings. All right, let's take a look at a hypertensive patient. Poorly controlled BP, they're having chest pains, or they're sent to the ED, or they go to the ED, and then they're treated, sent home. The primary care provider is going to get an alert. You can reach out to that patient, figure out what's not, was it just a once-in-a-lifetime issue? Is it something that's going to be reoccurring that he needs to treat so that it can be prevented in the future? All right, let's move on to Contribute. Contribute, we've always been getting data from the hospitals. We're really focusing on the ambulatory care setting. Right now, we're kind of gearing up to focus on post-acute care to get that information as well. Again, the idea is to get all the CCDs, get various forms of data in, build that patient's story so that whoever provides care for that patient can make truly and fully informed decisions. The CCDs, they contain no, I'm sure there's going to be elements within the CCD that are missing or that are useless, but there are tidbits of information in there that are of great use. Treatment plans, medications, demographic, insurance information, results, all of that's contained within your CCDs. So let's look at a specific contribute use case. Now, before we take a deep dive into this use case, I hear from a lot of facilities that I don't want to contribute data because I'm going to lose that patient, or our goal is to keep the patient within the four walls, or we don't want to give away our secrets on caring for patients. Well, the information within the CCDA is not going to differentiate you from your competitor down the street, because if your entire business or your entire plan for the future is built on problems, allergies, meds, results, well, that's not going to differentiate you from the crowd. It's really about ensuring that that patient receives the best care possible wherever they are. So at any rate, let's say you have a patient with diabetes. Again, their poor job at their glucose. When they go to the ED, God forbid, that hospital team can access the EHR or the HIE, too many acronyms. They can access the HIE. They can see the meds that you have that patient on. They can see when that patient was diagnosed with A1C. They can see the results. So they can look at those A1Cs and they can see that this patient does a poor job at their A1C, so that then that care plan that they develop during that inpatient stay or during that ED visit is going to be it's going to be more effective for that patient. And so the hospital team is going to be better equipped to develop that appropriate treatment plan. So, if you're not first, what I always tell folks, if you're kind of skeptical about contributing data, start by using the CHR. When you see the value of that patient information that you're able to receive, now step back and think, what would you pay for that? Well, we want your data. All we want is for you to give and make that story better. So the value that you see at the CHR comes from contributing data. If you're querying a patient, we really hope that you'll find the means to contribute data to that as well. So with an HIE that has deep penetration across a large geographical area, like the state of Ohio, that has a number of tools built within the HIE, it has great data being contributed to it, you can truly build a medical neighborhood. That includes not only your what you kind of think of as the traditional providers of care, the doctor's office, the hospitals, the labs, the physical therapy, post-acute, but you can include pharmacies, because we're seeing a lot more pharmacists become more involved in primary care or in providing care. The social services or the public health resources are becoming more and more critical to keep the patients healthy, to treat or to try to overcome some of the social determinants of health. Having all of this information together in the HIE makes the medical neighborhood stronger and can make for a healthier population. The best example that I've ever seen across the nation of a medical neighborhood sits right here in Columbus. The Healthcare Collaborative Greater Columbus has really, that's what I like to say, being from Appalachia, they really bulldogged this project. They took it on themselves to say, okay, we've got to set up, everybody had a list of a few social service agencies in their office. So if you had a patient who had food instability, you would send them to, you had the number for the local food bank to give them a call. But you probably didn't have all of the social service agencies, or there was some group that you didn't have access to. The Healthcare Collaborative Greater Columbus kind of took that on, built those connections with those social service agencies, worked with the HIE to kind of build it into the referral tool. This is a great quote from Carrie Baker, who's the president and CEO right now. The future of healthcare isn't just individual providers doing amazing work for their patients. It's connectivity among all providers, payers, and social services using relevant data to ensure that a patient's whole health is achieved in a coordinated and consistent way. I think, in the past we've done a great job with healthcare, but I don't think it was coordinated or consistent. Healthcare, the Healthcare Collaborative, they went out and they worked real closely with some important organizations, got them exchanging or receiving referrals, set them up the ability to receive patient information, or at least the patient information that they were allowed to by HIPAA if they were a non-HIPAA covered entity. Many of these organizations they don't have like an EHR or a CIM, CRM. They might have some application or Excel sheet or a Word document that they're trying to track patient information in, or client information. We can set them up with some electronic tools to at least be able to receive information and then update providers on the status of that referral. So now we're going to look at the referral tool, on part of which that the medical neighborhoods build. With this referral tool, it's web-based. There's not an integration point for it yet, kind of hoping to see something in the future, but it is a web-based tool where you can electronically send and receive customized patient referrals. The way it works is, if you want to receive a referral, let's say you're the food bank down the road, you say, here's the information that I need to receive so that I can help a patient who has food instability. I need A, B, C, and D. So we would go into the referral tool, build that site as a referral point, and say we need A, B, and C, and D, and make those required fields, so that way when that referral is received, they can say, all right, I have everything I need to help that patient. They can say, then they can update that status to say the patient showed up, we helped them out, we're closed out, here's the information back. It's a great way to streamline that referral process so your staff's not sitting on the phone calling, faxing, and it helps you close that referral loop. It helps you ensure that you have coordinated care for your patients. The way this works, within CliniSync, it's a closed loop referral. You go in as a provider of care and say, I need this service. You get presented with who provides that service. Maybe it's 2 or 3 folks. You select one. You send that information through the portal to the referring provider. They take care of that patient, update the status, and it goes back to that referring provider. That way, everybody involved with the care of that patient knows exactly what's going on with them. If you think back to that CHR screenshots, there was a referrals tab, so that now when you query a patient, not only can you see all that great information, their discharge instructions, problems, allergies, meds, if you go down to that referrals tab, there may be a way for you to devise some social determinants of health about that patient that maybe you didn't know. So maybe you're treating a patient in an inpatient stay. Maybe they just didn't share with you that they have food instability, or that you really don't have anywhere to live. But if you go down to those referrals, you can see that they've been referred to a food bank, that they've been referred to a shelter. Then you can say, hey, wait a minute, there's some other data, there's some other questions we need to ask this patient. The way the referral process works, we just kind of talked about this. We're going to look at screenshots. The screenshots we're going to look at is a real-world example where we build in a diabetes prevention program for the DPP up in Van Wert. This is a real-world example that we did as part of this project. So you got a patient. You have the patient in context. You can see here the patient's ADT4 last name test. We want to create a referral. We are going to select the provider. You can look under the service or specialty. In this example, we knew that we were going to, we were a provider of care in Van Wert. We were going to send it over to the DPP. We can make these fields required or just informational, but here you can input information on the reason why you're sending the patient, any comments, any supplemental information. What we did for this referral was The diabetes prevention program, a lot of them are set up so that they require the CDC pre-diabetes form to be completed. So what we did is we built in all of the questions that you'll find on that CDC pre-diabetes assessment form right into the referral tool. So that way when the DPP receives it, they know for a fact that patient meets the CDC requirements for the diabetes prevention program, and that Medicare is going to reimburse them appropriately. So we build in all of those questions. And you'll see here now on the referrals tab for this patient, the reason for the referral is the patient qualifies for DPP. You can see this all right within the referral tool. You can see here that you get a summary of the patient's information when you receive this referral. So let's look through use cases. We just gave you a great use case, referring a patient with pre-diabetes down the street or to your local diabetes prevention program. You can track the adherence. You know, if that DPP that received that referral updates the patient status like they should, you're going to know that that patient's adhering as a primary care provider. You're going to know that they've shown up, they're doing what they need to do. We're seeing some community-based weight loss programs that are having great benefits for patients with hypertension or with a high BMI. We can set those groups up as a referral point within the HIE. Again, you got a patient with diabetes or food insecurity, you can send that patient referral to a local food bank or to some local support agency or to a local diabetes nutritional education program at your local YMCA. The way the benefit of the referral tool is when a community comes together, decides they're going to use this referral tool, and really encourages those local social service agencies to become part of the HIE so we can build them as referral points. It really takes community effort, but it has a huge, huge, huge payoff. And that's why here in Columbus it's been so successful. We have the Bulldog. The Bulldog is the healthcare collaborative of Greater Columbus. They have taken this on as one of their projects, you know, went out, pounded the pavement, found those social service agencies, encouraged them to sign up, and really worked with them, the providers of care, saying, hey, look what we've got. We've got this great tool. Let's use it. And it's been a huge benefit, absolutely huge benefit. Now, as with anything technology related, there are some barriers to using an HIE. The big one is true EHR interoperability. All the EHR vendors will tell you they're interoperable, and they are many times to themselves, to other users of that EHR, or they've made a slight tweak to a standard, or as we see in bullet 2, there's a huge cost. You know, some of the EHR vendors charge tens of thousands of dollars, sometimes even hundreds of thousands of dollars, to enable all of the integration points. And really, you know, that's where as a user of an HIE, you see the fullest benefit when you are using and contributing and you know, just using the full breadth of HIE resources. We also run into semantic interoperability, and that's a big word for we call things different. You know, some folks use CPT coding, or they'll, you know, it's just really when we have two codes or two terms that mean the same thing, how do we dedupe that when we're saying them in a different language? There's a lot of focus on this across the technology vendors and, you know, those groups that are working on standards. How can we overcome semantic interoperability? Because if we can get all the interfaces working, we can get everybody contributing data. Now we just got to get everybody talking the same language. Another barrier is there is still a lack of HIE adoption across the healthcare spectrum. You know, the hospitals and the physicians, while Meaningful Use wasn't a perfect program, had tons and tons of problems, it's really kind of gotten us to where we are now with, you know, we can do some interoperability, we can do a lot of interoperability, we can do a lot of functionality, but the reason we could do that is because there were incentive funds for those provider types to, you know, to at least get the technology and implement it. We didn't see that in post-acute care. Now there are some new requirements for interoperability placed upon acute care There's no incentive funds for it, so it's kind of been slow going. Another issue that we have is an overly restrictive interpretation of HIPAA. Well, if you have patient information, you can share it with other providers of care and not violate HIPAA. We are a HIPAA secure entity. We're using software within our HIE that can track access of data, so we know who's accessing that data. By sharing the important thing to remember is sharing data with the HIE is within the confines of HIPAA, and we make sure that that's true. So do not sit on data thinking, oh my gosh, if I share this, what I know about this patient, and they haven't said it's okay, I'm going to violate HIPAA. There are ways that we can do that. You update your notice of privacy practice that says we participate in an HIE and we contribute your data. When that patient signs or reviews that notice of privacy practice, now you're meeting HIPAA, share your data. And the last barrier we have is what's called information blocking. Some vendors maybe have tweaked in, they're certified EHR, but then in the real world there's a setup that they had to put in place to make it work in your environment, but then blocks the ability to share data, or that there are some entities that may have implemented an EHR in a manner that doesn't allow certain data points to flow. We got to get past that. It's not your information. I hate to tell you, it's not your information. It's the patient's information. So let's do what's right by the patient. Easy ways to overcome some of those barriers. There's a lot of free technical assistance out there even today. Granted, the regional extension centers that were funded back in the Meaningful Use days, Kathy Costello, who set up the regional extension center here, and then when I came in as well, those dollars are gone. But there are other groups out there. There's QIOs, QINs. There's the Ohio Department of Health Technical Assistance, which we do get a little money for that to help folks with diabetes and hypertension within their EHR. There's a lot of other grant-funded organizations that will give you free assistance. If you need help, let us know, and if we can find a grant-funded organization to pass you to that can help you, we'll do it. There's grant dollars made available every day. Other funding sources to offset those interface implementation costs. That's, if you need one-time money, generally that's pretty easy to find those grant funds for. If you encourage other healthcare providers or state agencies or payers to contribute their data, because we're pressuring them, but they need to hear that same message from others across the care continuum, saying, hey, I'm sharing my data, why aren't you? Or I need your data, don't fax it to me, don't send it to me in the mail, contribute it to the HIE and I'll get it there. We've been pressuring payers. Our goal is that we will have both clinical information and claims data and be able to meld that together, because we just think anything we can get about the patient's story to supplement the information that you may have, that's what we want to do. Ensure that your treatment plans are included in your contributed data. That will really help with not only populating that CHR, but ensuring the best care for your patients should they seek care elsewhere. And make use of training and educational opportunities like this one from your EHR vendor, from your HIE, from groups like HIMSS. There's tons of free education out there that you can make use of that will help you in your day-to-day practice, whether it's clinical education or IT education or regulatory education. And just to let you guys know, last week we saw the 2018 physician fee schedule, the hospital outpatient, and the MACRA modifications for 2018. All three of those rules dropped. That's 6,500 pages of fun reading. I'm guessing that no one out there listening to this webinar is going to read all three rules. Well, Kathy and I are. We're going to read all three. There's a lot of organizations that are going to read at least one of those rules. Rather than read the entire rule, find these webinars, get educated on what you need to do going forward. What's the future look like for HIEs? Well, really, the goal of CliniSync, and I can tell you every HIE across the country, is they've got tons of information. There's an avalanche of information. We can drown you in information. But the goal is to take this information and transform it into knowledge. And what we're going to do is we're going to take all these transactional data points that we get, the ADT, the we get a blip over here from a hospital, a blip from post-acute, maybe, we get something from just any source. Those blips are great, but until, we can kind of put it within a reporting structure, a data mart, other ways to prevent that data both in a visual manner. And we're working on that right now. We've got some what we call the data mart that I know Adam and Dan and our technical team's working real hard to get to set up, that we're going to be able to provide these tools to you really, really soon. And those tools are going to improve over time. I'm really big on visualization so that you can really break apart your patient population by diagnosis, by 100 different ways to look at your patients, different registries, whatnot. And I really think that's where we're going to see even more and more benefit from the HIE. I apologize, I'm getting hoarse. We have another webinar coming up that's part of the Improving Ohio's Health series. We're looking at resources, community resources to help you meet your practice population health goals. We're kind of kicking around that topic. Kathy Costello is going to serve as the main presenter for that webinar, and right now it's scheduled for Wednesday, November 29th from noon to 1. The link's here. If you need this link, let us know and we'll send that out to you. If you don't have my contact information by now, here's another chance to send me an email. Kathy Costello's as well. Miss Kathy Rich, first I want to thank Kathy Rich before I move to questions. I give her terrible looking slides and she makes them look beautiful. She does a great job for us. She's our, Kathy Rich also takes care of all of our data that we collect as part of the ODH project and some other projects that we're working on, and just thank her. I just want to thank her because we don't put her name out there enough. Go to CliniSync right now, sign up for Dottie's newsletter. It's an outstanding newsletter. And now we're going to move on to questions. Give me just a second here to pull up my questions. And I just made the question box disappear. Questions. There we go. All right. What's the lag time between a registration, but not admission, to the ER and notify sending a message to the doctor to prevent admission if appropriate? First, I'm really wondering how long it's going to be before we start to see ED interventions, because I think there are those patients that every practice has that runs to the ED every time they get the sniffles, and boy, if there was a way to just call that ED and say, send him home, he's got the sniffles. Or if you're treating a patient, let's say you are a dialysis center, and you've got those patients that you're controlling very closely. You know when they're coming in for treatment. They get to feeling a little bad through the evening, so they just tend to run to the ED. You can say, send them home. We're going to see them tomorrow. They're due for dialysis. I think that is where we're going to start to see even more savings through the HIE. But back to the question, what's the time? It's around 15 minutes. It could be quicker. It could be longer, depending on servers and networks and all the activity and whatnot, but the average that we see is 15 minutes from registration to the notification hitting the notification type that was set up by the provider. And again, most folks are using the daily report or that web-based work tool, but you could set up a patient panel of your top 1% sickest of the sick patients and say, here's my panel, send me a text message or send me an email or whatever, so that then somebody could, through the evening, when you guys are closed and in bed, somebody could watch those patients and know when they present to an ED. Next question, what do you do with conflicts in data? For example, John Smith's Medicare birth date is an error, off by 1 day, but his license has the correct birth date and he refuses to notify Medicare of the error. What's his birthday in the CHR? Well, his birthday in the CHR is going to be whatever's entered into the organization's EHR, or patient management system, and it's going to be whoever entered it last. So if 5 people entered a birthday, we're probably going to see what was last in the CHR. Now, we do keep insurance history and some other historical information, but your basic information, date of birth, your social security number, your name, your address. We use those in patient matching. So even a wrong date of birth could result in duplicate records within the HIE, which we're always working to resolve, but it's just kind of the reality of having 12 million patients. So in the HIE, it's probably initially going to result in a duplicate record, and then once resolved, will show the most recent date of birth. In a perfect world, we would get a feed from Medicare or from Medicaid directly within the HIE, but we're not in a perfect world, unfortunately. Are commercial insurances like Medical Mutual of Ohio or others actively validating the insurance info on the parents in the CHR? This has been a real big focus over the last couple years. We have a couple of our team dedicated to working with the payers. The payers were initially set up. We have some. I don't have the list of payers that we have set up. We do have some payers set up. Some have asked us not to share that they are set up on the HIE, but we have them set up first to receive data. So they're receiving the ADTs, they're receiving results, other patient information that they are allowed to receive by HIPAA or by other agreements with the patients that are attributed to them or with other providers of care. We are now also working on getting them to send data through the HIE claims data, attribution lists, because we hear a lot from providers that they don't even know who's attributed to them by the various managed care agencies or whatnot. So we're really working to see if there's a way we can build that into the HIE. But I cannot honestly answer are the commercial insurances validating insurance info. But I will follow up with our team to see if that's something that they are doing or that can be done. Next question, what is the ORS requirement and how do we document that we are in compliance? Well, the ORS requirement is if you are going to prescribe a narcotic, that you must first query the ORS database to obtain the patient's history. You know, our goal is to prevent drug abuse. And the requirement is that you query that patient. I want to say it's at least once within 30 or 90 days. I don't remember the specifics of the requirement other than you have to do the query. Well, by querying the CHR, that query is sent on it's propagated to ORS so that we can prevent that medication information to you to meet that ORS requirement. There's other ways you can meet the ORS requirement. Some EHRs are integrated directly with ORS. You can also log into the ORS portal directly and query there. There's 100 ways to meet it. We just try to provide you with another means. What if the problem list contributed by many providers is a mess? For example, prediabetes and diabetes are both on the problem list. Who's cleaning it up? You know, that's a good example. That's a good question. Something we're working on. Something that every HIE is working on in the country. If you know, you got one patient, you get 5 problem lists. You're going to see duplication. You're going to see errors. And you know, I don't know what that answer is. I don't know how. If we receive, let's say we get diabetes and pre-diabetes from a patient, then the next contributor of care resolves the condition. That condition will come off the list down to the resolve, but there's a lot of work to do with that deduping. We do basic deduping now, but it's kind of deduping based on name. It's very, very basic. It's not that semantic deduping that we're hoping to move to here real soon. And it has a really vague answer, but it is a huge problem that's getting tons and tons of focus across the HIE space. Healthcare Collaborative, what is their relationship to the HIE? Are they duplicating what you do? No, we're partners with the Healthcare Collaborative. You know, they're a not-for-profit, we're a not-for-profit. We see them as a vital member of the HIE, and they see us as a vital member of the Healthcare Collaborative. We work closely with them. Actually, we had 3 folks at their conference yesterday. I was one of them, just to try to see, you know, the use cases from those end users, how we can, you know, modify the HIE or expand the functionality to make it a better fit for the healthcare collaborative. You know, they're essential to what we do, and we fully support what they're doing out in the field. I mean, you know, we have regular meetings with them. I think they've got a couple folks that are on what we call our CAC board. just a great bunch of folks to work with. Next question, we manage hypertension patients as nephrologists. We want to make it easy for other doctors to refer to us. How do I sign up to receive referrals? Give me a call. I'll get you. We got to get you set up as a member of the HIE using the tools, and there's several different ways you can receive referrals. Right now, most of the EHR vendors are set up to receive referrals through direct. We can work with you on that. There's some new functionality coming down the pipe where when you receive a patient from within your EHR, you can do a query and pull back information. That would include a referral if that referral was contributed by the other provider of care as a CCD document. Now, our goal, everything I demonstrated today was a web-based tool. Our goal as an HIE is for you to really not have to use those web-based tools unless there's no other way for you to access that information. We want to keep you within your EHR experience. We want to keep all your providers within the EHR experience because that's going to make them that much more efficient. So give us a call if you want to get set up to receive, and that you work with us, especially on those senders of those referrals. If you pressure them to become members and contributors to the HIE, it's going to make it that much more usable for you. So we're out of time. And quite honestly, I'm going hoarse. So I want to thank everybody for attending today. We did record today's session. I'll get it up on the CliniSync YouTube page here in the next few days. Kathy Rich will send the copy of the slides and a link to the recording out to everyone who's attended today. Thank you so much. I hope you join us for future webinars.